Okay, welcome everybody. I am Meg Laporte. I am the Executive Director of the Maryland Regional Direct Services Collaborative. And we are welcome everyone. We're very happy to have so many folks here with us today. Obviously this is a popular topic. Just a little bit of background on it. This webinar stems from a report that David Rodwin and I co-authored and released in March about the direct care and services workforce in Baltimore City. And this is the second webinar that has stemmed from that report. What we're going to talk about today is we're not going to just focus on Baltimore, but the entire Maryland region, as we discovered during the report that there is a lack of data and a lack of accurate data as well, in the direct workforce among direct care and services workforce. So before I let David take it away, I just want to do a couple housekeeping items. As I said, I'm recording it. If you could all please keep yourselves on mute during the discussion. At the end, we will have time for Q&A you can put questions in the chat as well. And I think that's it. So David Rodwin is going to lead an incredible panel of experts. And to introduce him, he is the vice chair of the collaborative and also attorney with the Public Justice Center. So take it away, Dave.
Thank you so much, Meg, and thank you everyone for joining this webinar on the importance of data and better understanding Maryland's direct care and services staffing shortage. As you've already heard, this webinar was organized by the Maryland Regional Direct Services Collaborative, and in particular, by its executive director, Meg Laporte. So thank you, Meg, for conceiving of this webinar and for all the work you put into organizing it. I'm Dave Rodwin, and I'll be moderating. I'm the lead attorney of the Workplace Justice Project at the Public Justice Center. And I've spent much of the last 8 years or so trying to make Maryland's home care and other direct care jobs better jobs that can support workers and their families. Most recently, as Meg mentioned, I co-authored a report with her funded by the Able Foundation. It was called Long-Term Services and Supports in Baltimore, a framework for improving job quality and creating a highly trained direct care and services workforce. And we'll make sure a link to that report gets into the chat. It won't surprise you, I don't think, that the central finding of the report is that these jobs generally don't pay enough to attract and retain the workforce that Maryland needs. And that was the subject of our last webinar. But it might surprise you, but maybe not if you've joined this webinar, that there's almost no publicly available data about the workers who do it. Meg did dozens of qualitative interviews to get the information that went into the report, but quantitative data is extraordinarily limited. We're very lucky to have 3 subject matter experts joining us today to talk about data in this space from their experiences and perspectives. First, we have Dr. Cheney Fabius, Assistant Professor of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. She's a gerontologist who comes at this issue from the perspective of a professor and researcher who has done a great deal of research on improving aging and disability policy. And in a previous life, she was a care manager in Connecticut for that state's Medicaid Home and Community-Based Services program. Second, Dr. Robin Stone, Senior Vice President of Research at Leading Age and co-director of the Leading Age LTSS Center at UMass Boston. Leading Age is an association of nonprofit aging services providers. And although Robin has had a variety of other relevant and significant positions in government and out, he currently represents a provider perspective. Third, Claudia Balog, Assistant Director of Research at 1199, a union of healthcare workers. Claudia has experience with these issues in many jurisdictions, in many different permutations, including Maryland, and represents a labor perspective. A very quick note on terminology. There are lots of different names for the direct care and services workforces, but the people we're talking about today are those paid to provide personal care and support services and do related work in homes, assisted living facilities, adult medical day facilities, and nursing facilities. We're generally not talking about RNs or LPNs. We're talking about home care workers, nursing home workers, etc. And before I get started and turn to the questions, just a quick reminder to everyone to please mute yourselves. We'll have time for questions at the end. Meg, I think maybe we might need you as the organizer to mute anyone who's not currently muted. Shani, let me first turn to you. Could you please tell us a little more about some of the research you've been doing and what your experiences have been with data in this space? What data does exist and what data doesn't exist?
Absolutely. So again, thank you all for inviting me to join the panel this afternoon. My work has largely focused on addressing inequities, racial and ethnic, as well as socioeconomic inequities in long-term services and supports for older adults, their family caregivers, and the direct care workforce more recently. And I've been in Baltimore for about 5 years. And so some of my work, my first sort of purview into working and learning more about the direct care workforce came by way of conducting a statewide survey of residential service agencies to understand how they support direct care workers, as well as we had a specific focus on Alzheimer's disease and related dementias, just because it's such a growing concern in long-term services and supports. So we asked a few questions about specific questions around how they supported people living with dementia. What I learned is that we had a publicly available list of RSAs in the state, but that essentially was it. And there were names, addresses, things like that. So my research team and I went through and cleaned the list a bit, and were able to survey or administer surveys to about 1,000 RSAs in the state. We had a pretty low response rate, which I kind of blame COVID for, because we did conduct this survey in 2021. But we asked specifically about, are there vacancies at your agency? Whether turnover has increased or decreased or stayed the same since COVID. We asked about the role of direct care workers. We asked how people were supported, supporting families of people living with dementia. And some of the key findings, we had about 177 RSA administrators complete that survey. Some of the key findings were that like more than half of our agencies said that 3/4 of their clients were living with some form of dementia. But only 14% of those agencies required dementia-related training for their direct care staff. So that is a mismatch in our opinion. They also really highlighted the supportive services that they provided to families, but there were things that stuck out around, especially around COVID, around the turnover and the reasons for turnover, not having the supports to substitute workers when the need was there, not being able to send out an additional worker when a worker needed to stay home or take care, or they didn't have additional benefits were lacking, things like that to support the workforce when they were needing them. And so I think that sort of COVID sort of scratched the surface on underlying issues that already existed. The other thing I'll just say that we did was we took a small number of those surveys, about 35 agencies. We were able to link to the Medicaid home care NRI assessments through partnership with Hilltop and the Department of Public Health to look at what agency level factors were associated with care experiences of older adults and their family caregivers. And so we found some counterintuitive things that agencies that provided more support, like family caregiver training and dementia care and things like that, oftentimes are bearing the largest burden of need, which doesn't say that these agencies aren't doing their job. It just indicates the huge demand for these services, I think, and supports. And so I'll stop there, but that's just some of what we've been doing. We've done also some qualitative interviews. But to answer your question about data, we had to get the data, right? There was nothing or no data source that we could go to. And I will say that Maryland is not an anomaly in this, that this is a national issue. It's just that the direct care workforce is not the easiest group of folks to get to identify, to survey, however you want to collect data. So it is a national challenge, but we also have a national demand for these services. And so I'll stop right there.
So that's really helpful. And a quick follow-up on that point. So Maryland has a commission to study the state's healthcare workforce crisis. And I have to say, I think it's been doing a great job on a really tough and really broad and really intractable issue, helped along by Casey Tiefenwerth's facilitation. I see she's on today. And the commission just released an interim report that I'll put into the chat in a moment. But the very first finding of the interim report is, I'll just quote from it, workforce shortages are difficult to determine with the currently available data. Is that finding consistent with your experience researching direct care and services workforces?
Yeah, I would definitely say that. I mean, the challenge with data is like I said, it's not a Maryland specific issue, but oftentimes people have to rely on larger federally funded sort of data, or larger national, I should say, nationally representative data to make assumptions and conclusions about the states that we live in. So for example, the American Community Survey reports on, different types of workers, but there are, trade-offs to using those data. The Bureau of Labor Statistics provides information about the workforce, but there are trade-offs. That is not the same thing as a state having the data available for those for information to be gathered from. So I think that is an accurate statement.
All right, so let me turn now to Claudia. So Claudia, in your role doing research with 1199 SEIU, your work requires you to dive into the data of different states and jurisdictions from DC to Massachusetts. What are some examples of data that Maryland does not collect that other jurisdictions do?
Sure. Again, thank you for having me. So I think it's helpful to break it down into two buckets of sort of what you're looking for and why you want them, right? So there's this piece of who are the workers, right? If we need to actually reach workers and communicate with workers and identify concerns, workforce concerns, we need to have data on who folks are, and I'll speak to that in a minute. And then the other bucket is sort of like what data exists that's available where we can glean working conditions, where we can glean wages and benefits. So I'll give an example. In New York State, there are cost reports submitted to the state that cost reports filed by providers that break down whether workers are salaried or hourly. It breaks down their job titles to the extent that there are nuances in these home care titles, whether people have additional certifications or, everything from, home health aides to homemakers, right? There are different titles of caregiving in this subset. We can see from these cost reports total wages that are spent. We can see the value of benefits if benefits are being paid. We can actually see what are the highest wages and lowest wages for workers at those agencies in those titles. They also provide total staff counts. An agency will provide how many workers they employ, and they report the number of vacancies they have. They also document whether they're employing live-in aides or 24-hour cases or the overtime they pay. And New York State isn't alone. It's an example of more robust data, but Washington State has been using cost report data for some time. Texas is beginning to identify those future workforce development needs. Now, on the thing that I referenced earlier, that piece of like, well, who are the workers? There are states that also have registries of home care workers. So New York State and Massachusetts are areas that my work falls into where we're looking at, how many workers are registered to provide these services. California does as well. And there are states that are now exploring this and are, I think, farther ahead. So Maine, for example, has put up a workforce dashboard that really reflects coordination between their Department of Health and their Department of Labor, and actually their Department of Economic Development, where they're really trying to target communications to existing caregivers in this workforce and folks that they'd like to pull into the pipeline. And other states that are exploring communicating with this workforce more broadly and understanding, well, what is the universe we're talking about? Who are the workers? What are they being paid? Those
Or
include
do it on Zoom.
those include Wisconsin and
Yeah, or do it on
Carolina
Zoom.
and Maine. So
Okay.
I agree 100%. The
Okay, yeah.
it-
Bye.
And I'm sorry to interrupt, Claudia. I think
Austin, but I'm in the
Lori,
middle
I
of
think you might be
one.
unmuted still. I don't know, Meg, if you're able to mute her. I apologize for interrupting.
No problem. So there are states that are definitely being intentional about what kinds of things we need to collect.
Thanks. And there's a new proposed rule from CMS, the Federal Center for Medicaid and Medicare Services. And it's gotten some press recently because of a wage requirement that's associated with it, that workers need to get a certain percentage of the, that home care workers need to get a certain percentage of the compensation that the state pays to home care agencies. But there's other parts to that proposed rule, right, that concern data. Could you talk a little bit about what that rule would require states to collect in terms of, and publish in terms of data on these workforces, and how you view that proposed rule?
Sure. So in April, when the Biden administration released this proposed rule that is explicitly aimed at improving access to Medicaid home and community-based services, the foundation of that access was in strengthening the workforce. So the rule lays out really specifically that workforce shortages are impeding access to care, and approaches the solutions to the problem from that workforce lens. So in addition to the 80% of Medicaid payments, so yes, 80% of Medicaid payments under the proposed rule would have to go towards compensation for home care workers, such as salary, wages, benefits, and it includes payroll taxes as well. Now, to do that, CMS is would require that states improve transparency in the industry. States would be required to publish standardized data regarding home care payment rates every other year. And it implicitly requires the kind of cost report data I was discussing earlier that we just don't have here right now. And states would also be required to set up, to establish interested parties advisory groups. Now, these would be advisory groups that look at reimbursement rates, look at payments to home care providers, and look at access data, and develop recommendations on what those rates should be to strengthen the workforce. I want to just note one thing. I think there's a great illustration of what good reporting looks like, but also why it's so crucial to have. And it's actually just sort of 30 miles down the road in the District of Columbia, if I may. So like in 2014, the Department of Justice uncovered rampant Medicaid fraud by some providers in the District of Columbia's home health program. And the district's Medicaid agency, the Department of Healthcare Finance, started collecting really detailed cost report data. That data showed that there were home health agencies receiving Medicaid dollars in the district who were not paying their employees the living wage. The living wage at the time was like $12 or $12.50 an hour. And the cost reports showed that workers were actually being paid $10.50 an hour.
Was that living wage a requirement? Were they required to pay that?
Yes, it was. And that's where this story goes, because workers immediately realized discrepancies and problems, and they went to the district's Department of Employment Services. That's the district's labor agency. And they ran into a wall because the real problem was that the Department of Healthcare Finance was providing payments to the agency providers that baked in the living wage. So providers were already receiving funding from the district that took into account that workers were supposed to be paid $12 or $12.50 an hour, depending on what year you were looking at in these cost reports. And so the cost report data isn't just an exercise in paperwork burdens. It's about the ensuring that tax dollars are stewarded properly.
And these cost reports we're talking specifically about the Medicaid funded sector. We're not talking about private,
Correct. And the private funded sector, is really a whole other conversation on data. But certainly I think that the Biden administration is really acknowledging that, okay,
Come here.
workers, we have a recruitment and retention problem. We believe that it's grounded in no small part to wages and benefits.
Come on.
And we really need
Move.
states to not
Move.
only
Jackson,
throw money
move.
at the
Come
problem,
on.
but to gather the data,
No, let's go.
that they need to show that tax dollars are being used in a way that really improves access to services.
And the CMS rule, it's sort of, in addition to being a rule that if it becomes a final rule will take effect in a few years, it's also sort of a policy statement, sort of like the Biden administration's, here's what good state fiscal management of Medicaid care policy looks like. Is that sort of your view?
That's our view. Yeah.
Yeah. All right. So Robin, let me turn to you. So you've got a lot of experience and right now a national level focus. What sorts of data should states like Maryland be collecting on direct care and services workers? And are there any examples of things states are doing well that you're aware of?
Sure. Thank you, Dave, and thanks everybody for being part of this important webinar. I do think data are essential in terms of decision-making and transparency and understanding how we actually set good policy and good practice. I am a researcher by training, but data is not an academic exercise. In the 21st century, it's a travesty that we do not have better data on this workforce. I would say that we probably do a better job with the nursing home, with the certified nursing assistant population, partly because CMS, the nursing homes are regulated at the federal level. There are standardized requirements for nursing homes to report, including some new requirements that came to be a few years ago that required payroll-based journals so that all nursing homes must report their payroll information in a very standardized fashion. Before that, we were getting all kinds of turnover and other kinds of data that just didn't make any sense and were very inaccurate. But now, because they're actually using a payroll-based journal process, this is now much more accurate in terms of being able to look at staffing data, turnover data, retention data, information around wages and benefits. And then, of course, the Medicaid cost reports are also required for the nursing homes. So I think where we really have, and that's not to say that we have great data on the certified nursing assistants themselves, which it's been talked about before, but I think we need to understand the distinctions. As somebody who works at a provider organization now for the past 23 years, and who believes very strongly, I always say to our members, it's the people, stupid. This is not this is a very labor intensive sector. It's all about the people that are doing this work. 60 to 80% of all the hands-on care and services are delivered by frontline care professionals, certified nursing assistants, home health aides, home care aides, personal care attendants. So in the LTSS space, whether we're talking about residential or home care, these are the staff and the labor part that we need to understand better. Yes, we need to understand nurses. Yes, we need to understand social workers. Yes, we need to understand some of the other positions. The vast majority of work is done by these folks. And so we do not have great data on certified nursing assistants. At the national level, the last time that national data were collected on certified nursing assistants was in 2007. And in home care, it was 2004. So we are very far behind. Some states do a much better job than others, both in terms of, I would say, more in terms of getting data from providers. Very little has been done around getting data. Cheney talked about doing one survey of a part of the sector in terms of having to go out and find this workforce. There are a number of states that are now requiring surveys. Probably I would look to Wisconsin as one of the most comprehensive states that has really been focused on collecting really good data, both from the provider settings as well as from the individual caregivers themselves. They have done a series of surveys for each setting and each population that is served under home and community-based services. And hopefully this is not a one-time deal, because the fact is you can't do one survey and say we're done. We have to do surveys at least biannually and to actually see what happens and what the trends are, to help us do our planning around setting rates, looking at best practice in terms of what the states can do in terms of supporting investments and on the training side, as well as implementation in agencies or in consumer directed programs. So I think Maryland would do well to look at some of the things that Wisconsin has been doing, both around workforce surveys. They have a statewide workforce platform that they have developed. They have a whole activity around career opportunities where they are involving both the Departments of Health and Human Services, Elder Affairs, and the Department of Labor. And by the way, I do think that there needs to be total integration around this workforce between the Departments of Health and the Department of Labor, because both have to work together around how we're going to actually do a better job of data collection from both the provider side, as well as data collection on the individual folks who are in the workforce. New Mexico just passed a new law where they are trying to strengthen the caregiver frontline professional data infrastructure for the state. So there are states that are certainly much more in the forefront of this data collection than Maryland is, but I think we've got a great opportunity to try to figure out how we make this happen in Maryland. And I would also say, before I just stop for a minute, that years ago, I've been around long enough because I've been in this now for 47 years. So I've aged in place, and I'm now an old person who actually could use services, maybe, hopefully not for a while. But in the old days, we used to have something called health planning agencies. And my chair of my dissertation committee at Berkeley years ago actually ran the health planning agency program for the state of California. In those days, we had great data on workforce at all levels, by district, by geography. That function went by the wayside. I think Maryland really needs to think about the importance of understanding the supply that's going to be there today and tomorrow. We do nurse surveys, we do physician surveys, but we really don't understand the supply of this workforce. And I'll tell you, the demographics and the data at the national level suggest that we're going to have long-term shortages, which is probably going to vary by market. But if we're going to set up HCBS programs and try to reform the nursing home without a labor force, we have to understand the supply shortages, both in the short term and the long term, so we can actually do planning around how we, number one, create viable quality jobs, but number two, get a pipeline and folks who are actually going to work how much technology do we need to build in to either complement or supplant some of this labor? And these are going to be essential information that the state is going to need to make really significant decisions about how they allocate resources. So that's why I say data. Some states have done a much better job. Cheney and Claudia, I think, both underscored the fact, particularly on the home care side, this is a difficult population and set of populations to gather information on. If we had really good, solid registries, where at least we had a baseline for being at a universe to be able to actually go out and find this workforce, I believe it's actually should be part of the public health function in the state to actually, as part of surveillance that we do, emergency preparedness, for example, if we're going to be prepared, we've got to have this workforce, and this workforce needs to be trained to understand that today we're going to have over 100-degree temperatures, and they need to be watching out for all those older adults that are much more likely than any other population to die from heat stroke. So, I mean, it is an example of how these data can be used to actually support really good decision-making by the state, as well as setting up really much better wage rates, looking at the transparency that Claudia talked about, where you've got a discrepancy between where the money goes and how the money is flowing to the workforce itself. These data can be used in a number of different ways, including what Cheney does, which is actually to look at interventions and kinds of things that we can improve the work in the workforce. If we don't have the data, it's really hard for us. There's only so much you can do from storytelling.
That is such a great point, that if we're looking to try to improve things without the data, it's extraordinarily difficult. And like you say, very difficult to make informed policy when you're driven by what's available, which is storytelling. I know there's a lot of expertise in the folks who are joining the webinar just to join, but just so that we're all on the same page, HCBS is home and community-based.
Home
In
and
other words,
community-based service.
Medicaid-funded home care. So just a very quick follow-up, Robin. So one argument I've tried to make over the years in the context of other, is that in the context of other publicly funded work in Maryland, like state-funded construction work, there's an extraordinary amount of data that private contractors, private businesses have to give the state, including the actual biweekly payroll that the contractors have to certify as being correct, showing workers hours and pay, among other things. Medicaid is also public dollars, but Maryland collects almost no data about the tens of thousands of workers doing Medicaid funded home care. Do you have any thoughts as to why that might be?
Well, as I said, it took CMS at the federal level, and then of course the states had to follow suit to begin to use payroll-based journaling for the nursing homes, and that was after a substantial amount of issues around challenges with how these data were being reported, errors, and all of that kind of thing. And it's much easier on the nursing home side because of the structure. Number one, you actually got the federal oversight, as well as pretty serious regulatory processes at the state level. And furthermore, you've got nursing home CNAs that are captive within the building.
But aside from the difficulty, of course, in home care is in private homes. It doesn't mean it's not possible to still get data.
No,
it's
it's absolutely possible. But I think there hasn't been the pressure to actually do this in the same way. I mean, I absolutely agree that it should be, and I think I call the home care world the Wild West, because it is really a Wild West out there, whether you're trying to do research on it, trying to look at quality, trying to protect the workforce, and even trying to understand high-performing agencies. So I just think that it's been there's a lot of variation across the states, particularly on the Medicaid side, which supports a lot of the home and community-based services. Probably a little bit better data collection on the home care, home health care side, and that's because of the Medicare payment, which basically drives Medicare home health. There is Medicaid in there as well, but it's not as much of a state function. But the Medicaid program is a state function, and it is a responsibility of the state to
Yeah,
do this, just as you would do. I mean, if, I actually believe you're talking about the private employers. I actually think we should be talking about private employers also on the home care side. But we should at
let me,
least,
and I'm sorry to cut you off, Robin. I just want to
Go
make sure
ahead.
we get to but really great
Yeah.
points here. And as I turn back to you, Cheney, I want to just, in terms of the data that we do know, which is from, as you mentioned earlier, very broad sort of publicly available data like Bureau of Labor Statistics, Federal Bureau of Labor Statistics surveys, wage surveys, which are really quite general, don't distinguish between what's publicly funded and what's privately funded. The workforce we're talking about here in Maryland anyway is overwhelmingly Black women. And in particular in the home care space, historically, these workers were excluded from the protections of bedrock federal labor law. In 1938, for example, when the Fair Labor Standards Act was passed, it excluded all domestic workers, which was interpreted to include home care workers. That only changed in 2015. And just to inform this next question, what sorts of information about these workforces in Maryland is the lack of data preventing us from answering?
Well, I think that, Robin hit on it, in a few different ways. And it really, for a lot of part, in addition to understanding wages and things, and I apologize in advance, I have a sick little boy coming down the stairs. Right as you're asking me my question, post-COVID things that we deal with, right?
We're pro-care in this group.
Well, you all might meet the person that I have to care for in a little bit, but anyway.
I've actually met him already. He's been on Zoom with me and Cheney a few times.
Wonderful. So, I think that one of the things I'll say quickly is the piece about quality that I really, would want to emphasize is without understanding information. Of course, there's a twofold, the descriptive information about wages and things like that. And as well as, from my research and my interest is really understanding how workers and families collaborate to deliver high quality care. Because there are also, and I won't go into, implications for family and unpaid caregivers when the direct care workforce is unavailable, right? When that piece of the ladder, rung of the ladder is falling off, there's a greater demand that has implications for employment, family employment, and a lot of other ramifications. But I will say that the quality piece is really challenging. Of course, it's hard to measure. We don't have a uniform measure of quality like you do in Medicare home health or in nursing homes. But if we can't understand at the bare minimum whether wages, for example, are associated with any sort of care experience, whether it's associated with turnover, whether the availability of the number of workers, part-time versus full-time, the availability of benefits, have anything to do with the type of quality of care that people are receiving, I think that it makes it very difficult to know where to intervene. You don't know if it's solely a wage issue. You don't know if there's a training issue. You don't know if there is another issue related to support. And I think that, the findings that we found from my survey, where we linked the data to the Medicare and Medicaid HCBS NRI assessment data, just was sort of a very baseline introduction of identifying potential areas for intervention. But in terms of the type of information that you would need to move forward, it was a very small, like I said, we only were able to pull in 35 agencies. We surveyed over 1,000, right? And so I think that that just sort of gave us an introduction to say, oh, there are probably some levers here that we can touch on, right? Whether it's the type of training that's made available for direct care workers, whether it's the supports that are provided at the agency level. But without the data, you just don't know. You don't know. And so, I think just to say that, just to reinforce that, without data, there are many things that start to sort of either collapse or that we're just kind of shooting at in the dark.
Yeah.
And Dave, I would like to just follow up one real quickly, because I do think we had a conversation around this, and that is that I'm going to say this and, take it with a grain of salt, but I think there is around this data collection issue, wouldn't necessarily call it structural racism, but I do think there is an issue of the undervaluing of this workforce. I mean, the same thing is true for certified nursing assistants, but they finally they were able to make, because there you also have a predominantly female, non-white workforce, largely a quarter to a third immigrants. This was a undervalued workforce where there was not seen any value, almost dismissed in terms of collecting information to even figure out how to make some of these decisions. And as we've talked about previously, Dave, that many of this frontline home care workforce was considered domestic work. There wasn't even the notion, I mean, I try to use the term care professional because I just came from a meeting a couple of days ago where one of the aides was saying, we see these jobs as our profession. We are professionals. And so once you start to understand that, there is something that is then the value of the data become much clearer. And I think there's been a serious undervaluing of this workforce in the history, at least.
And may I jump in for a second, because both Cheney and Robin really hit upon like two things that I've been thinking about in this. And number one is we have an absolute black hole in what tools caregivers need to find success in this career. We don't know the level of their infection control training. We don't know whether they've received dementia or memory care training. We don't know how many of this care force is bilingual, as we experience an aging population that requires culturally competent care. We don't have the slightest understanding of how to place people who will find success in these caregiving roles, right? So I am absolutely 100% in the camp that this isn't just a wage issue. But I want to get back to something Robin said about communicating again with people who need information, and the pandemic really exposed that. So in Maryland, all of the responsibility to provide updated important information about infection control training, how to safely care for your clients, PPE, and frankly, essential workers were offered benefits. How many of those workers were communicated with about those benefits? Because all of that information was delegated to the provider agencies. Now there's 1,500 agencies in the Wild West, and Robin, I like to call it the Wild West as well. It's just the Wild West on steroids here and in a lot of jurisdictions. But 1,500 agencies just in the Medicaid space alone were the frontline communicators to that care force. And I honestly believe that, yes, as a state and as an advocate for workers, the state has a responsibility to be able to communicate critical life-saving information, not just for both workers and for the people they care for. And it really, really hit home. Again, COVID ripped the Band-Aid off, exposed everything that we've been saying for a number of years, but it was all magnified.
And I really appreciate both of you, Robin and Claudia, adding your points there, because I was about to ask you the very same question I asked Cheney, and repeat that question to each of you. What questions are we unable to answer without this data, bearing in mind the historic marginalization of these workers? And Claudia, I see
I have one more thing that we don't know. We don't know how many of these workers work multiple jobs, because we know anecdotally and from discussions with our membership that there are CNA, GNAs who work in skilled nursing facilities who have, all kinds of regulated training that are in these home and community-based settings. but we know that they're moonlighting second jobs because we need to create an industry where one job is enough. But I would think if that's one of the first questions we always want to understand is like,
Yeah.
how many spaces in the spectrum of long-term care are you providing your skills in?
Well, and especially relevant during the worst periods of the pandemic, when someone who's traveling to multiple people's homes in the same workday might be a vector for disease, not
Yeah.
intentionally. And just very quickly to each of you, just with a few seconds if possible, because I want to make sure we get to some questions. In terms of how this data in an ideal world would be collected, analyzed, and made public, better to do that internally, in other words, build the capacity of a state agency to just collect and analyze this data as a matter of course, and publish it so that it's available to, for example, researchers like Cheney who are trying to examine additional metrics that the state may have not analyzed, or contract it out. Just in a few words, if you're able to.
I'll start, and I'll throw my hat in the camp of it really needs to be done internally and in Maryland for extra special reasons. So this is where I'm going to jump in and say Maryland's healthcare system and our regulatory system and our reimbursement system in healthcare looks different than any other state in the country. We operate under something called a total cost of care model. It's a hospitals driven model, but the state of Maryland as an entity is very concerned with ensuring that people receive quality care and that the state is stewarding our resources properly. And where I'm going with this is hospital readmissions. So our total cost of care model is very centered around hospitals and very centered around rate setting for hospitals and ensuring that hospitals don't have to readmit people, right? We want to reduce hospital readmissions, and that's all.
Nadia, I'm going to give you 30 more seconds.
Yeah, and we have to fold in data from post-acute settings to understand if we're getting where we need to go in ensuring quality care under our total cost of care model. So that's my pitch.
Robin, your thoughts?
Yeah, I would agree. I do know that there are some states that contract out a lot of this work. And actually Maryland, I think, does some work with Hilltop, and probably some other entities as well. I think optimally, it would be much better to have some real capacity internally. First of all, these are, again, data collection and analysis is not a luxury. It is something that is actually essential in the 21st century. I mean, my God, we're moving into artificial intelligence, where everything now is actually going to be done at that level. And if we can't even figure out some of these basics, we are so far behind. So I think capacity needs to be built internally at the state level. And I had a couple of questions around who takes the lead in this. I think we really need to think about what is that infrastructure. As I said, we used to have health planning agencies in the old days that actually had the responsibility for a lot of this across the sectors. We need to think about that, but I think optimally it's best to try to keep it in-house and grow some capacity and then do collaboration with external partners.
Great. And Cheney, over to you.
I would agree, and I won't say too many more words outside of understanding. The one thing I would say is that I think that the surveying and data collection piece is very important, but I also would say that there's a need to the existing collaboration, for example, that the state has between themselves and Hilltop could be leveraged, right? So there's probably data points that exist that we've not yet taken advantage of. I can't name them, I don't know, but there are probably data points that already exist in the data that you could gather, make conclusions of. Like from my standpoint in home care, perhaps you could figure out how many people are receiving care from the same home care agency without going out and doing that data collection. But I will say that I think for the long run, it probably absolutely makes sense for the state to have the internal capacity to be able to you know, at the bare minimum, be able to collect that sort of, that financial data and as well as demographic.
And
Yeah, and
Dave,
when-
Dave, can I just say one more thing and then I'll be
Yes.
quiet? I mean, many states, for example, have used ARPA funds for the
American
American
Rescue
Rescue.
Plan Act funds.
The
yes.
American Rescue Plan Act dollars have been invested substantially across the country, mostly in workforce. You talk to a state, you cannot understand anything about what worked and what didn't work because they have not built the data capacity to actually understand how they can look at what they've changed. They've upped wages. They've done wage pass-throughs. They've done all kinds of things. We do not know whether anything is working or not working. It has got to be the state responsibility, going back to taxpayer dollars, that they have the capacity to start to look at some of that.
And I know, Cheney, when you and I were speaking to prepare for this webinar, you mentioned as part of your work in Connecticut, you were aware of University of Connecticut doing quarterly analysis for the state, sort of on a contract.
Yeah.
And so it wasn't a one-time, one and done. They submitted an RFP, they did a report, they got paid, and then they moved on. It was an ongoing collection, analysis, and publication of data.
Yeah.
And that just made me think, you know, in addition to, I had sort of been thinking, well, it's about who does it, but you made me think it's not just about who does it, it's about how frequently it's done.
Yeah, I mean, in Connecticut, this is specifically for the Money Follows the Person program. They've had a long-standing relationship with the state from the outset, almost, of MFP in Connecticut to be the evaluators. And so they employ the research assistants that go out and do the surveys for the evaluation. They make they create the reports, but it's a relationship between the state and the University of Connecticut to help improve those services. But they are done quarterly, and they provide those reports quarterly. Yes.
One other example of that is the Scripps Center at Miami in Ohio. They have had a long-standing relationship with the state, and they do all the work on LTSS. And it is fantastic work because it's a real collaboration. It's not just here's a RFP, go do this, and it's done. So.
Yeah, and we're about to turn to questions. We only have a few minutes. I'm sorry about that. I do want to just take a very quick moment to recognize some folks who joined today that I was looking at in the participants column. I saw Delegate Sandy Rosenberg, who chairs the relevant subcommittee on the Health and Government Operations Committee. Delegate Ken Kerr, Delegate Kim Taylor. I know Senator Bidel was joining by phone. And I also saw Jenna Crawley and Andrea Nunez from the Department of Aging. I mentioned Casey from Department of Labor, Casey Tiefenworth. I see some folks whose names I don't recognize, but it says MDH next to their names, which means they're from the Department of Health. So thank you all for joining. And I know everyone who's joined today has an interest and is a stakeholder in some capacity and has lent their expertise to this. So, all right, let's turn to questions. I'm happy to maybe go through the chat and answer some. If anyone wants to ask a question verbally, they're welcome to put their hand up and using the hand raise function. And I'm happy to call on them in that way. So I'll just, while we're waiting for that, I'll just go down. And I know Ron Carlson, former executive director of the collaborative, who I think had to hop off early, asked a couple questions about, what agency is in charge of this? Is there a lead agency? I don't know if maybe Claudia, is that a good,
Yeah, so in Maryland, all of the data is housed for different reasons in different places, right? So in acute care, the HSCRC collects a lot of workforce data in the form of hospital job surveys, though those have looked different in the last few years. The Maryland Healthcare, on the long-term care side, the Maryland Healthcare Commission has a role in collecting some of this. The Office of Healthcare Quality is collecting licensure information from provider home care agencies. There's data that's submitted through electronic verification visit records of workers visiting clients in the Medicaid spaces that are collected by MDH. There's no I wouldn't necessarily argue that there's a lead. And to the extent that the Labor Department collects anything, Cheney has really summed it up, that Bureau of Labor Statistics is doing occupational workforce surveying, but we can't get granular in the way that we need to understand the kind of care work that is happening and what the universe looks like.
So basically, it's a hodgepodge of different agencies and sub-agencies, and there's no one that's tasked with, tell us about this workforce. It's different agencies have different sort of micro responsibilities, and there's no collection and putting it in one place for analysis. Does that sound right?
That's accurate.
Yeah. All right, Dr. Bandari, I see your hand up.
Yeah, thank you for a wonderful presentation. Actually, I agree with Robin. These workforce should be paid well to retain in this difficult field, which is, it takes a lot of tremendous patience and training. And Robin mentioned, the funds from American Rescue Plan should be used. If I'm correct, state has a surplus of about a couple of $1 billion. So that would be very good thought to consider allocating some money to this.
We did have a surplus. I think more recently, unfortunately, I think current estimates show it no longer existing, but your point is well taken. Any other questions anyone would, I see one, what reforms are needed? Can you say more, Christina, about what SOC codes are?
Sure, that's the standard occupational classification codes that the BLS at DOL uses to track these workers. And right now there's just the 3 for, I think, personal care, home health aid, and it's also homemaker, right?
Yes, and this makes me, when you're looking at federal government data and looking at how they're breaking down the workforces into different categories, like you say, they're overlapping, personal care, there's two other terms at least that are used. And that makes me think of what I said at the beginning of, there's lots of different names for these workforces, which makes it really difficult to drill down. So any thoughts, Robin, or anyone else on this question?
I mean, there has been a small group of folks. PHI has been one of the organizations that has sort of taken the lead around this, that actually have been thinking about this and discussing with BLS. I will tell you, as a former Fed and also having tried to get changes in the BLS codes, it's not an easy thing to get even one code change. So, but there is a lot of discussion around trying to figure out how to at least get more specificity around the codes, because they're very limited. They overlap. They're very broad and confusing. And so there does need to be work done around this. And I do think that requires advocacy really at the federal level to get BLS to change these. But there has been some work, Christina, on looking at this.
Can
And
I just,
oh, sorry, go ahead.
I'm sorry, I was just gonna plug, is that I think too, one of the things that Christina is highlighting in this question is like the difference between federally assessing something and at the state level, because even if there's just so much overlap and variation in how states call out or name different services, that I think even reclassifying them, they may apply to one state's set of services, but there's such overlap, I think, across, which is why there's that additional need for states to sort of collect their own specific.
Yeah, I think that's a great point. I mean, it's really difficult to extrapolate from the federal data to states because of the tremendous variation that there is at the state level.
Yeah, and let me just turn it to Jenna, because I see your hand is up and we're at 1 o'clock. So this will be the last one.
Hi, good afternoon, everyone. Jenna Crawley from Maryland Department of Aging. And first of all, I just want to say thank you for this very timely discussion, and with the level of expertise, both locally and nationally, is incredibly helpful to what we are looking at doing and advancing at the Maryland Department of Aging. I just want to share with everyone who's on the call, because so much of what was discussed is the need for cross-sector collaboration And that as part of the Maryland Department of Aging and under the governor's leadership and Secretary Roque, we are in the process of developing or advancing a multi-sector plan for aging, and workforce is certainly one of the areas in which we need to be focusing, along with all of these HCBS services that you're talking about, both from, sort of the person-centered approach, but then also all of the providers and the backbone of that system, as we know the workforce is. So I would invite you to learn more about what our process is. We are currently working toward an executive order from the governor to establish this. And if there are any policies, and certainly, Robin, thank you for the laws that you spoke about in some of the states that are leading some of the data capture within and analysis within this space. So if you have anything, please send to me. Also, I just want to call out Andrea Nunez, who's on the call here and is our legislative director. And you will be seeing the Department of Aging taking a more active role in the policy space. And I see some of our elected officials here on the call as well, and absolutely would welcome more opportunity to talk about how we can work together and partner across our sister agencies, across our decision-making agencies, and legislative partners to really be impactful here in Maryland. I think we have a real opportunity to be more transformative than we have been. And then also, just the last thing I'll say is we are participating in the Centers for Healthcare Strategies multi-sector plan for Aging Learning Collaborative. And so more information to come, but we will have access to technical assistance and also subject matter experts who are within some of the states that you've named and others who have been really successful. So just wanted to put that out there. And if anybody desires more information or would like for us to come and meet with you, we would be happy to do so. So
Thank you, Jenna. And I know I'm speaking for myself personally, I'm really excited about what you, Andrea, and the secretary are doing at the Department of Aging. And I'm really excited to see what you all put together. And I was just scrolling through the chat. I missed that there were some other questions. I was scrolling down from the top. I'm sorry that we're not getting to everyone's question. I apologize. But I want to thank you all for joining and spending this hour with us. I want to especially thank our panelists, Cheney, Robin, and Claudia, for lending the benefit of their experience and expertise to all of us. And again, want to recognize all the elected officials and policymakers and implementers of policy who took time out of their busy schedules to join today as well. Meg put a link in the chat to sign up for emails from the collaborative. You can learn more about other opportunities like this one, other webinars that we plan on putting on. We do plan on doing another one in a couple months. So again, many thanks again to all of you, and have a great rest of your Friday.
Thank you.
Thank you so much.